Welcome to the Dove Education Network Research Institute Report 2024. Welcome to the Dove Education Network Research. Today, the Dove Education Network presents a presentation for the test for relationship. My name is Dr. Elizabeth Barkley. I am a quantitative clinical researcher. Today, I will be presenting on the obesity epidemic, which is part of my larger health education series under the Dove Education Group. The goal of this presentation is to highlight the urgent need to address the global obesity crisis through research-driven initiatives, with a specific focus on the public health impacts of obesity and strategies for better healthcare outcomes. Many researchers, the lay public, governments, initially focus highly on the nutritional aspect of obesity, whether a person had the nutrients, whether they were overeating some products that was promoting the effect of it in their bodies. The focus on nutrition and how obesity relates to nutrition has been misunderstood and underrepresented for many years. In this study, I hope to reveal some truths and dispel some myths that obesity is not a nutrition-based disease alone, that there are co-relationships and partnerships that need to be addressed. In 2000, the World Health Organization declared that obesity rates regionally, globally, went sky high, and the numbers have been climbing since in different parts of the world. Obesity has said to be affecting 890 billion people worldwide, representing 1 in 8 individuals. Currently, obesity affects over 890 billion people worldwide, and representing 1 in 8 individuals will be diagnosed with obesity. The financial burden is staggering, with global healthcare spending estimated between 2 to 7%. And in the US, this figure reaches $147 billion annually. Obesity not only impacts personal health, but it also has seen across healthcare streams, across several other industries, which is why it's critical for science, for researchers, for medical practitioners, for the lay public to look at this story of obesity as a conglomerate all over across the world and address the root causes, dispel the myths, and hopefully implement effective treatment plans and options. This means that we need to ask some questions here. If obesity is affecting every culture and every system in the world, some look higher than others, some seem to be managing, others seem to be growing exponentially, then the question is it a nutritional factor? Are there biological factors? Or are there other determinants that we may not be considering as a growing underlying current that is now surfacing across the world? In order to help me explain the results of the study, I drove not only the theoretical framework, providing a comprehensive understanding of obesity and the interactions and the interplays of relationships, but I also looked at how we define obesity, where it came from, and who defined it to help us reach conclusions to understand relationships. The body mass index, BMI, remains one of the most widely used tools to assess obesity. However, while it provides a helpful benchmark, BMI does not account for the genetic factors I've discussed, muscle mass, lifestyle habits contributing to a person's overall health. And it means that while BMI can indicate obesity, It doesn't tell the full story about a person's health risk or what they've been at risk for or exposed to. As a result, there's a growing conversation and talk points about improving how we even measure and look at the origin of obesity. If someone who eats out of control gains weight and has that weight, I argue here that that's not the same thing as someone who was sick or had a health condition and because of the way they were medically treated, triggered obesity in their body. Those seem to be two different applications of obesity. And my argument is also that they need to be treated as two different episodes and effects on the human body. The insides of the human body can tell us more than the outside of the human body. What we have been discussing and what most people classify as obesity is when they look at how a person looks from the outside. They seldom understand the physiological aspects of health in someone's body and how, depending on the chemical balances or imbalances in the human body, we can get movement that is securing a person's health, or we can get movements that cause a lot of issues in the human body. I have seen people who are not classified as obese based on BMI having a lot more health problems than I myself, who, from my physical physique, people would look and say, my gosh, you are overweight based on the BMI and the scale alone. However, when you compare my medical record to other person's medical record, you may see that they have a longer list of issues where I do not have a longer list. I may have a specific problem, but my genetics and my physical form does not dictate what is reading on the inside. And this is very much a part of the theoretical framework we need to discuss and some of the ways in which some of these concepts are bumping into each other and causing even greater confusion about having a clear line relationship understood between whether or not interventions can work or not work in specific individuals. With recent innovative changes in healthcare overall throughout the world, coordinated efforts to align and define obesity continues. While some diseases are blamed because of obesity, there's a very strong argument in the literature that shows that some of this is wrong. That in fact, what we have today from some of the conditions in the body are co conspirators that are causing these issues and have triggered conditions where it slows down the effects that normally we expect the metabolism to work, to kick in and burn some fat cells away. When that doesn't happen, clinically, there are barriers in the body that are shutting down one process and starting another. I remember having a conversation with a surgeon in the health spa. Surgeon was nice and tall and skinny, and by all societal definitions, she was the beautiful one. And there I stood next to her with my fat self, with attempting to go exercise in the gym. She's sweating and I wasn't. I asked her, what is the difference between you and me, Doc? You and I come here every day the same way, and we have this almost the same approach. You go swimming, I go swimming. I feel good, and you come out sweaty and looking like you have 10,000 pounds of worry on you. And she looked at me and said, it all depends. I asked her about my condition and surgery and why was that done to me? Why did medical science make that choice and it triggered this? I showed her a picture of me before the surgery, before I was diagnosed with this condition. And she said, I'm so sorry. We just didn't have the knowledge and the control back then to stop what they did to you that triggered the other things. We're aware of it now, and some of us are trying to do something about it. And then I asked her the follow up question, what do I do until then? And that's where the conversation changes, where depending on where we are, the leadership, who's running the program, may also foster whether or not the patient is being treated, their body responds to interventions, or we have to change the entire 5 layer to another choice. The issue here is without enough information, we don't know whether the relationship will work or not. I studied over 300 key pieces of literature and again could not find the line between some of the arguments I am posing to you. My core arguments suggested the gaps between all of these. However, in healthcare, when we want to find out information, we study these particular sets of areas, especially in healthcare. We look at interventions that have already taken place. We look at genetics and lifestyle. We look at comorbid conditions. We look at physiological behavior, healthcare access, how much training practitioners have in order to make decisions on what and how are the most critical areas where some results may show of what we are studying. Based on the comparative search I conducted, I found that the best way to design my study and the methodology that would respond to answer the question that I am posing for this study was to study the numerical data and evaluate relationships in obesity. So I employed a retrospective causal comparative design, drawing data from public health records. I stratified it by the participants that participated in the studies. Back in 2020 and 2020, there was a lot of data, a lot of health records because the government started a program called Healthy People 2000. And as a result, in the last 10-year span, I was able to find robust research, but I went 20 years instead, so that to our current year, it is within the 5-year range expected. And I looked at people who were answering the research question through the health survey and the interventions they use in order to lose weight. And we call that a non parametric, really random design where I would use a Wilcoxon based test that takes non-parametric information and test it. And since BMI is my focus across the hospital and the commercial based programs, this robust design helped me develop the methodology in order to find statistically whether there's significance in the relevant real world situation application of a relationship. In my design and methodology considerations for this study, being that I designed it to be a retrospective, looking back 5 years, quantitative causal comparative design, because the numerical aspects of answering the research question would be better dealt with by using this design. I looked at the data from 120 participants. I initially pulled 200 records out of the archive data found in the CDC and CHS databases, and I targeted randomly pulling out records and looked at how they answered survey questions that determined what fit into the study and which didn't. As a result of that method, I was able to follow ethical guidelines in the Belmont study and in the American College of Education IRB process to gather and form my 120 participants from archival records that were retrospective. And from this group, I was able to also split between two groups: people who use the hospital based system to find their intervention for weight loss, and people who use commercial means. The data was stratified through various demographic factors to ensure I could form a comprehensive analysis. Using a stratified sampling technique, archived records of individuals gendered aged 18 through 60 that were coded in these records or where they made statements indicating whether they were in morbid obesity and had a health risk problem, were counted for the study. They were participants in either a health program, hospital based, or commercial based. And based on anthropometric science coding that I spoke about earlier, Ansel Keys developed this system, and it was developed by the World Health Organization and the American Medical Association in the American system. We were able to find the codes to each of these in the code sets that is laid out for the medical community to understand that when I see E66 point something something, that means that this person is in an at-risk category for obesity. Based on this factor and the data set I collected, I was able to then form my data that I would then analyze. Body, we have to consider the natural foods we've ate, how it interacts with us, where it grew, where did we grow, what country, how did our parents raise us, and what did we do? These are key indicators that you are exploring, not just accepting answers. And within some of the foods that we eat was supposed to be the medicine per se that would be received in our bodies and heal us. But when that is not happening, and utilizing tool packs in the Excel matrix of quantitative science, I used the Wilcoxon sign rank test to examine the relationship between the participation in an obesity management program and BMI reduction. I measured the research question 1. Was there a significant difference between BMI suggesting a relationship? And I measured question 2. Was the significant difference seen because there was a relationship between the hospital and the commercial programs, between the BMI loss? Which one of those programs showed greater BMI changes? Based on the major numerical analysis and evaluation of the analysis, there was a clear, strong evidence of reduction in BMI among participants. So the first question has been met. Was there a relationship? Yes. There's a relationship between the BMI and participants getting involved in either a hospital program or a commercial based program. So the question of, will this work? Based on my study, I said yes. If you join a program, hospital or commercial types, I did not define the types of hospital, commercial. This is a generically designed area. If you join one of these, there should be change in your BMI. This argument goes back to the beginning of some of the arguments in the literature right now that says we don't know if it's going to work. We don't know whether it was the patient or who did it, because some people claim they're not going to even try to lose weight or BMI because none of it works. Or some physicians use different methodologies because they simply do not understand the relationship factor that I have tested here, that if we have a program, we should have outcome. And for whatever reason, if the insurance carrier is not paying the bill, because they also say this patient has been in a program for 6 months and there has been no change reported. Why? I would support the insurance company because my research says there should be some change. We may not like the change, we may not like the data it is given, but there is change, and yes, it does work. Therefore, we can rely on a little bit of this to make some other program determinations. Based on this data, in fact, the key finding of this study shows that hospitals had a higher amount of reductions when patients
however
enter
small.
the
It could be
hospital
20 pounds, 30
and
pounds
followed the
when the
program
BMI is
there,
translated.
that there was
But commercially
more
as
reduction
well,
of the BMI than
there
in the
is a response.
commercial-based program.
And
And you
this
can
is
see that here,
critical
where
to
the
know that
commercial-based program is
this
lower
research has been
and
answered.
the
So if you go
BMI
and join a
for the
program and
hospital-based
your action is to
patients who
join,
entered
and the
these programs
reaction
were
of the
higher.
program
Now, this is
interacts
great
and is
news for
able to
some people.
confirm
And later I will
your
discuss
registration, your
possibly what
longevity
could
of the
have
program,
happened,
then
what
this says
and
that there's
why
going to be some
the hospital
success.
seems to work
And this is
a
very
little bit better
critical
than the
based
commercial.
on this
But I
data.
want to emphasize here that when I
Hospitals
tested
had
whether
a
there's a
higher
relationship,
amount of
it does
reduction,
show on both sides
however
that
small. It
BMI
could
will
be
change
20
if
pounds,
for a
30
duration of
pounds
time
when the BMI is
patients entered a
translated.
program.
But
This is great
commercially
news.
as well,
In order to provide a full understanding of my findings, I also used statistical methods that looked at descriptive statistics along with my Wilcoxon test, looking at non-parametric randomized data collection, measurement, regression analysis to evaluate the relationship, and the scatter plot to correlate that relationship and see it moving across time. My conclusive analysis on this relationship using all of my calculations shows that in the commercial program, something happened to participants where the weight or the BMI did not shift as much. Whereas in the hospital based program, something occurred which caused a regression or a drop. That is significant because here it's 210 and here is 67. And the factors measured between these two show that we do have a significant shift in the duration. And I want to dare say that hospital based programs are going to be more consistent and use the same type of behavior to measure the patient's outcome versus commercial. We don't know. There's so many commercial plans. There are some that are pills and some that are fruit based, some that are exercise. I did not define. I threw the group together if they said they were in a non hospital based program. And here we can see then that that has meaning and that requires maybe an additional research. To further support my argument that there is a relationship between participants' time in a program and whether their time was in hospital or commercial, when they started, their weight was at one level, and when they finished, it was at another level. And through time, we can see the longer it went on, the more the change in the participants along the path where they started and where they were going to end. This is also good news that the initial weight versus the final BMI score did have changes as it moved up across time into the greater time periods, as well as the patient was exposed to interventions, there was effects happening to them. There's a relationship there. This brings us to look at the implications of healthcare and leadership training, education, and consideration. And also, I want to add here what the general public is told about the relationship between obesity, their own personal choices, versus clinical information that states that it may not be choice related alone. This research has profound implications for healthcare leaders. First, it demonstrates that obesity management programs do have responsibility, particularly those in hospital based may be more effective at reducing BMI. Leaders should prioritize these thought processes as you're looking at allocating resources. Commercial programs can benefit from this education as well by integrating probably preclinical education that most hospitals would do, medical supervision, structure, time, and support to emphasize the collection of data and how that data is collected to show effectiveness. Combining these strengths, I believe, will produce and optimize obesity management programs that can ensure that they can answer the question, yes, we can produce a relationship and show proof of that relationship as the causal factor in why BMI changed or will change in a patient's outcome. That's a great commercial point. Highlighting here my causal comparative analysis for research, I want to boost the confidence and implications objectively because numerical science is all about objectivity. So, first, I indicated that pre education research may have an impact here. The goal would be to establish a solid foundation for the research to be done for every patient. While right now we're saying there's a epidemic, we have no proof whether it's the market causing the epidemic because of all of our collective behaviors, spending in healthcare, spending in the market, buying food. We're on exercise programs, but then we go right back and eat the French fries. Is that causing the problem? The method of that, while literature review is good, we also want to have individual interviews. And we want to look at survey data very closely. The survey data that I collected from this created this study from archival records of patient records that were over 5 years ago. And now I was able to formulate this study and produce results from it. So it is absolutely critical to have such data around, which means there's a responsibility by the clinical teams and the scientists to collect that data accurately. So, encouraging the transparency and integrity. When we want to maintain that in the scientific research community, we communicate that. So, if that the data was not collected correctly, or the patient did not do the program fully, while I did not measure it in this research, I measured it for future research. I will, because fostering trust and credibility in the data helps us to educate and to formulate the accurate information that will produce the right results. If genetics is going to work better for one group over another group, we need to tell that group that. If the eating programs are going to work for one group over another group, we need to share that information so that they can create the right formulary of medications. Farmers may grow fruit in nutrient rich cells. We may not come up with some fad diets that will harm the population. Transparency is highly regarded in the scientific community as $1 million. Accountability also, making sure that we are doing check ins and providing documentation detail, reliability and validity of research is very important for us to ensure that we can back up our studies because most of these studies are used to formulate medication and public knowledge. In this study, I relied on using several features to back up my data. I retested the data along the way. I retested the questions that I used in the research. I retested my own methods twice. I researched each movement of the line that you saw in my scatter plot, each patient, their before and their after. While I did not show that here, I actually have separate calculations for each of the 120 to measure each of their scores to make sure that I was not overstating or understating their value. Yes, it takes a lot of hard work to do those crunches, but that is why we have a lot of tools in our tool pack in order to numerically accurately calculate and configure the data research findings. For the purposes of leaders that may come across this study and learn from it, I want to point out to you that it is absolutely important that we ensure that there's visual representation of our studies. We need to make sure that continuous learning and development is stated in what we are recovering, discovering, and reporting. Empowering collective movements is also important. That there are a bunch of people who are given opportunities to review our study and say, yes, we concur, or provide their collective opinion on what could be done to improve it, or what are some gaps that they are seeing that maybe we did not see in formulating our design and our methods for the study. This fosters trust in the global community of people rather than just isolated events. Now, my favorite is to do studies on specific patients and specific events within their study pattern of how they're doing things. We often do this in education research in K 12 by looking at test scores from one year to another. When we do that, those are fact based findings that are hard to argue. In obesity research, it's very difficult to rely on just one set of data even across, unless you're doing a long term study to evaluate one patient over time or one group over time. But the argument is always going to come back to, who did you compare this to? I compared hospital based groups to commercial based to come up with my findings. But what does that say? Would the same findings occur if I were to choose another year? Would the same findings occur if I chose another season or state? How would I be able to find the methods and the answers? That takes extensive development to happen. However, I believe it's worthy of us encouraging that development so that as accurately as we can provide information, we're able then to predict better outcomes per patient, per region, per country, per epidemic, per pandemic. It is clear that the recommendation for future research has to be that we look at a large scale genetic. Geneticists are finding that obesity problems, and then based on the biological factors of the ecological movement across time of how weight occurred, traditional methods versus innovative approaches now in medicine, that we do need to look at this on a wider scale. And that's why some researchers have entered the Genome Wide Association Studies, GWAS, where there's a large collection of biobanks of large genomic information collected from DNA samples in all types of people across the world. All types of factors are being tested, all types of situations. I dare say, even our food is experimental at this time because scientists are pushing to find evidence for many diseases and many cures. The issue over time is we are looking for absolutely exact figure answers. And right now, there is no literature that can combine all of this to form a picture. That's why the onus of pressure comes down to the individual practicing clinicians, the insurance companies in the Americans that use this to pay for their patients, to receive treatment, and so on. We have to do individual research while in the background continuing to do large scale research. That's the best basis for coming up with the best treatment options for patients instead of experimenting on the patients themselves. At Dove Education Network, we empower justice. We never rest with the first result. We will provide follow up studies. We will provide opportunities for focus groups to come together and continue this very powerful discussion on obesity so that we may be able to find even more relationships. And maybe we will find programs who encompass a comprehensive view of obesity that they've come up with a treatment or individuals have discovered their genetics tied to their socio-ecological factors is producing results. I'm interested in many more follow ups, and we will produce many more shows to provide this forum. Thank you for joining me in my study that I conducted for the American education so that we may be able to empower justice through information.